All right, so now we're going to talk about pain management in children, a little bit different than adults, including dosages, including methods of distraction, etc. There are a few things I want you to really take away from this chapter. I want you to know the pain scales that we talk about. I want you to know the developmental aspects of treating pain and assessing pain. Excuse me. I want you to know a lot about Tylenol and Motrin because you'll be given those a lot. We talk about sedation. We talk about topical pain management, like if you're doing a laceration, suturing a laceration. So when we go through the chapter, there's some parts in here that are nice to know, and then there's some parts in here that you need to know, and I'll let you know those. All right, as far as the PowerPoint goes, again, lots of information that's nice to know. Talks about pain transmission. I'll let you read through that. Classification of pain, either it's acute or chronic. Etiology and source and location, important to know for assessment purposes. Some things that might influence how patients either perceive pain or react to pain. Their age, their gender. Boys tend to be more stoic. I don't know if that's 100% true, but that's what the literature says. Temperament, previous pain experiences, very important. If they've been in the hospital or if they've been to a doctor's office and they've had some sort of traumatic pain experience, then they're going to be definitely more reactive when it comes to pain. Some myths and conceptions. There's a chart in the book or a table in the book that explains this. None of these are true. Newborns don't feel pain. Yes, they do. We use a lot of, instead of pain control like medications, we use sucrose, put it on their, sugar water, put it on their pacifier, let them suck. The sucking soothes them, and the sucrose seems to have an effect like a pain medicine. Infants have very little memory of pain, and small children, untrue. If they come to the hospital and they experience any pain at all, that's what they're going to relate their hospital visit to next time. Indicators of pain in infants. So infants are very hard to judge pain. A lot of times every time, of course you can't ask them, hey, does your leg hurt? So you have to assess them in a different way. We use the Flack Scale to assess infants, and I would definitely know the different parts and the different components of the Flack Scale. Physiological changes like increase in heart rate, increase in respiratory rate, sweating, those are all indicators of pain in infants. When you talk to older kids about or assess their pain, you want to use terms that they'll understand. So make sure that you're using age-appropriate language. All right, some things that might affect children's response to pain, the type of pain, whether it's going to be a quick, instance of pain and then no pain, or if it's going to be something that's going to hurt for a long time. This is a new a pain assessment. I've never used it before, but it has some good information. So you question the child, you use the appropriate pain scale, you evaluate their behavior, because they can tell you, oh, it's a 10, and sit there and be laughing and playing. So you evaluate their behavior, get the parents' buy-in, take the cause of pain into account when intervening, and then do something about it. You always have to address your pain, whether they're a 10 and they're sitting there laughing and playing with you, or they say that they're a 1 and you can obviously tell that they're in pain. So you always need to do something about it. Distraction, warm compresses. If you can't medicate, then you can always, turn the lights down or give them a warm blanket if they don't have fever, etc. Some health history data related to pain assessment. You always want to get the location, the severity. Always get your pain scale assessment. When did it start? What makes it better? what makes it worse, etc. Any belly pain, you always want to assess for nausea, vomiting, diarrhea, or sore throat, because strep can cause abdominal pain. So make sure that you ask about any associated symptoms. Also, if they have a headache, ask about recent trauma. If they say my leg hurts, ask about recent trauma. Sometimes they don't realize that I hit my leg on the couch or whatever. So always make sure that you investigate that. Here's some pediatric pain assessment tools. Now, some of these I've never heard of other than in the text, but the ones that we use are the FACES scale, and that's usually the preschool, school age group. We use the number scale. Ask them rate your pain on a scale of 0 being no pain, 10 being the worst pain you've ever felt. Where does that fall? And that's usually for older kids. I don't know if there's a bottom age, but it depends on the developmental level of your child too, and the ability for them to relate those numbers to an actual value. And then in the infants, we use the Flack Scale. Here's the FACES scale. You can do 1 through 5. We usually do 0 through 10. Either or, just be consistent. Sometimes you have to explain this to them a little bit too. Like 0, this is no owies. 10, it hurts so bad that you're crying. Which one of these are you? All right, and here are the ones that used for infants or for nonverbal kids. So take this into consideration if you have a developmentally delayed patient that really can't tell you that they're in pain. You can take you can get the assessment cues like increased heart rate, crying, things like that, but you may have to do a Flack scale on them as well. So if you have a 13 or 14-year-old nonverbal cerebral palsy patient, then the Flack scale may be the appropriate scale. When you're treating pain with kids, you want to make sure that you individualize intervention. What works for some doesn't work for all. Non-pharmacologic approaches, distraction. There's some listed in the text. We'll go over those. Distraction, warm compresses, repositioning. Those are all good non-pharmacologic ways to treat pain. Distraction, turning on the TV, watching a movie, those work great. Here's some examples. And here's some examples of some non-pharmacologic behavioral things, imagery, changing the subject. Sometimes just getting their mind off of it helps. With infants, the non-nutritive sucking with the pacifier, that works great. Heat and cold, massage, those all work good with infants. Be careful with the heat and cold though. You don't want to, their skin is very thin, so you don't want to get too hot or too cold. Sometimes just wrapping them up if they're like a newborn, if you swaddle them, that helps as well. All right, some factors that might affect your choice of pain med, whatever the drug is being administered, and this status, whether it be their level of consciousness or their anxiety level, the type, intensity of location of pain. If it's a 4 or 5, then a Tylenol or Motrin might work great. If it's a fractured arm and it's a 10, Tylenol's not going to do much. Plus, they're probably going to be NPO for a procedure, so you don't want to do anything by mouth. Here are some different choices that we have. We have just a general analgesic, non-opioid, and we do use some opioids in kids. Anesthetics, sedatives, and hypnotics. Hypnotics, I don't know how much of that really happens. Preferred routes, and we're going to talk about different meds with different routes. Oral, if they're not NPO. If they have an injury that might require them to have a procedure, please think about that before you give them something by mouth. Rectal, if they're vomiting and they have a fever, rectal Tylenol is not a bad idea. IV, I did not know you could give Tylenol IV until a couple semesters ago, and they do use that, I think more in the OR setting. Topical local nerve blocks, if you're going to suture, if you have a fracture that you have to reset, like in a finger or a toe. If you're going to take off a toenail, a local nerve block might be used. And then epidural administration, post-surgical, they use that a lot. And then conscious sedation, if you're going to do a procedure where you need your kiddo to be still and not remember much, conscious sedation can also be used. Some common effects, just like with adults, constipation can be a side effect of opioid medication. Need to be careful in kids that are immobile, like femur fractures. These kids aren't moving around a lot, and if you're giving them a bunch of pain medicine, constipation could be an issue. Itching, nausea, vomiting, those are all adverse effects that go with opioid medications. All right, when you're working with sedation, these kids aren't totally out, so they're not intubated. They're just kind of in a twilight sleep. Good teaching prior to the sedation with the family is very important. A nurse's role, you are the monitor. Okay, so you're monitoring their level of consciousness. You're monitoring their airway. Always have your reversal agents on hand when you're doing a moderate or conscious sedation. Make sure that you have your emergency equipment, your suction, everything is right there that you need. Oxygen, maintain that airway. All right, procedure-related pain. And this is talking about like suture repair, laceration repair. Sometimes when we incise and drain an abscess, we have some pain control techniques that we use during those procedures. Topical anesthetic, even starting an IV or drawing blood, okay? We use something topical to help numb the skin. Non-pharmacologic child life is usually involved. They're doing some distraction with the iPad or with an I Spy book. Make sure you do prep your family ahead of time what's going to go on. I always tell them, they're probably going to fight me a little bit, so we're going to hold on to them pretty tight, and they probably won't like that. So you kind of prep your parents for the worst. Use the smallest gauge needle if possible. Venipuncture in newborns, you can use, heel sticks. If you need a huge amount of it, we very rarely do heel sticks anymore. They probably do a lot of those in physicians' offices, for bilirubins and things like that. And give them that pacifier with that sucrose on there. It works wonders. All right, so let's go over to our chapter and hit on some high points there. Okay, let's see. This explains the physiologic aspects of pain. You can read through that. Kind of interesting. All right, and this talks about acute pain, chronic pain. Just know the difference. Acute pain is something that's going to probably go away. Chronic pain is something that the child's going to have to deal with for a while. Some factors that influence pain. You need to read through this section. Age and gender, cognitive level, temperament, developmental level, previous pain experiences, very important, big player. Family and culture. Different cultures deal with pain in different manners, and they teach their children to do the same. So make sure that if it's a culture that is very stoic, you take that into consideration when you're doing your pain assessment. All right, here's the part, that I love, the whole developmental thing. Talks about infants reacting to pain, what you're going to look for. Facial expression is one of the things that we assess for with the Flack Scale with infants. So here's some physiological responses to pain. Their heart rate's going to go up. Their O2 set may go down. They may be sweaty. Of course, they're going to cry. Toddlers can be out of control. They are the slipperiest little boogers when they get sweaty. So have you some holding help if you're going to do something like start an IV on a toddler. Preschoolers, school-age children, adolescents. I'll let you read through those and how they react to pain. Very different. Here's that table that I was talking about myths and misconception about kids in pain. So make sure you read that. One of the things down there, they are truthful when they're asked about experiencing pain. Not always. They can either be truthful in telling you they have pain and they don't, or the other way around. Truthful, they tell you that they have no pain and they really do, because they don't want to get poked, or they don't want to, they don't want to have blood drawn. So be careful when you're assessing. Here's a good old nursing process. Always assess your pain, go back and do something about it, and then always reevaluate. Okay? Always reevaluate. Remember that part. Here's the FACES scale again. A lot of places, a lot of the pediatric hospitals have them on their badges, so that you can, when you're assessing a child, you just pull out your badge and show them the FACES scale. It does describe the other pain scales, the Oucher pain rating, the poker chip. Again, not very common. The FACES is the most common for that age group. The Flack Scale is down here. Again, there's a couple of different neonatal infant scales that they do explain, but the one that I want you to know is the Flack Scale. Cries, you see cries sometime, but the Flack is the one that's used the most with infants and with nonverbal older kids as well. So you need to know the Flack Scale. They either get a 0, 1, or 2 in each category, and you need to know the categories that we assess. We assess the face for facial expressions, the legs if they're drawn up or if they're kicking, or activity if they're laying there quiet, then that's a 0. If they're screaming, crying, then that's a 2. Consolability, can you calm them down with a pacifier, or can, when mom picks them up, they calm down? So they are rated on a scale of 1 to 10, and whatever you find, 0 to 2, 0 to 4 usually is manageable. Anything above a 4, then you need to do something about it. Okay, so that's the Flack Scale. And then with the adolescent or the school-age kids, the number rating scale on a scale of 1 to 10 is appropriate for them if they are verbal and they can make that connection between this is a 10, this is a 0. All right, so we've assessed our pain, so now what are we going to do about it? Always start with the least invasive. So if you can do a distraction, or turn on the TV, or give them a warm blanket, that always is best. We tried non-invasive first. Relaxation. There's some distraction techniques. Bubbles. You can't ever go wrong with bubbles, I'm telling you. Always have your bubbles in your pocket. Imagery, biofeedback, thought stopping or changing the subject. That's always good. Positive self-talk. Sometimes that's a little harder. It's a little harder for them to talk away the pain, but that coupled with some SpongeBob on TV, you might be in business. All right, here's some information about sucrose in infants. Study to read. Again, that evidence-based practice coming into play. Heat and cold, massage and pressure, all important in infants. All right, so here's some teaching guidelines. And these are for the patient as well as the family. Might be good information to carry forth into clinical to teach your families on how to deal with their child's pain. This talks about one of the maybe the Prep U assignments, one that a lot of students get wrong. So if you see those little misconception alerts, you might pay attention to those in the chapter. All right, so then we've tried our non-pharmacologic interventions, let's talk about some pain meds. Okay, non-opioid pain meds. The two most common are acetaminophen and ibuprofen. Let's use the generic terms. Ibuprofen, Advil, Motrin, all the same thing. So if your parent, and a lot of times the parents don't realize that. So that will be a good teaching point. If they come in and they say, oh, I gave them some Advil and then I gave them some Motrin, they've given them the same thing. So make sure that they know the difference and make sure they know what ibuprofen is and what acetaminophen is. Now, acetaminophen can be found in a lot of different medications as well. It's not just straight up Tylenol always. Sometimes it's a component of a fever reducer cold medicine. So when you're taking your med history, make sure that you get that information as well. If they come in with congestion, cough, say, have you given any Tylenol cold or whatever. Well, not Tylenol cold because that's going to be pretty obvious. But some of the other cold medicines might have some Tylenol in them or some acetaminophen in them. So make sure you do some good questioning. Now, in clinical, every child that you take care of is probably going to have Tylenol and Motrin ordered. So you need to know the doses. Tylenol or acetaminophen is 10 to 15 milligrams per kilo per dose, and you want to do a max of 5 doses a day. And it can be given every 4 to 6 hours if you need it. And it can be given for fever and pain. Motrin, or ibuprofen, 10 milligrams per kilo per dose, and it's Q6 hours. Of course, you don't want to go over 4 doses a day. So know those. You'll use them every clinical that you have. Aspirin. Okay, so let's talk about aspirin. Adults take aspirin for pain. Why can't kids? Well, it shouldn't be used in kids because it has a risk with Rye syndrome, which is a neurological syndrome that we'll talk about in the neuro section. There are a few occasions where you'll see kids on aspirin, and those kids usually have or had Kawasaki disease, and it's used for the coronary effect. So if you see a child that has aspirin prescribed, be investigative, okay? See why they're taking it. Also, if parents come in and say, I gave my kids some aspirin, tell them no aspirin. In normal, healthy kids, no aspirin, okay? They do not get aspirin. Pepto-Bismol has aspirin in it. So if they say, now the kids' Pepto-Bismol doesn't, but the adult Pepto-Bismol, if they come in and say, I gave them the pink stuff, the Pepto, educate them on that as well. Pepto-Bismol has aspirin in it. You shouldn't give your child the adult version of Pepto-Bismol. Okay. Opioids. We do use some opioids. We use morphine. We use fentanyl. We don't really use Demerol in kids. It has some CNS effects that you don't want with your kids. We do use some like Lortab elixir, our post-tonsil and adenoidectomy patients. A lot of times they go home with Lortab elixir. So there are some opioids that we use with kids. Now, be careful because morphine, of course, has respiratory depression effects. So you always want to make sure that you have your reversal agents on hand when you're giving morphine. They always need to be on a pulse ox if they've had an opioid. So those are some nursing considerations to take into account. All right, common drug. Oh, we just talked about these common drugs. There's acetaminophen, there's ibuprofen, and again, like I said, I did know that you could give acetaminophen IV until about a year ago, so you can give it IV. Ibuprofen only comes PO, and I say that they do compound a topical ibuprofen at some of the pharmacies around here, so if that is, if your patient can't take PO meds, they don't have a G button that you can give them through, then that might be an option if you can find a compounding pharmacy. Toradol, we give some Toradol in children. It's either given IV or IM. And then our opioids we talked about, mostly morphine and fentanyl. Mixed opioids, I've seen Stadol given to a teenager that had a migraine one time. So don't really use those a lot. They can cause a lot of nausea and vomiting, just like in adults, so sometimes some Zofran is on board as well. All right, some local anesthetics. I don't know if you've heard of Imla or Elamax or the cold spray. We do use those when we're talking about doing procedures with kids, IV starts, lab draws. So let's go down here and look at that information. Imla is a topical cream. Elamax is kind of a cousin to Imla, so you'll hear both used. Imla takes a little bit longer, takes about an hour to numb up. It's a topical cream that you put on and you put an occlusive dressing on top of it. It works well like kids that have ports. Parents will put Imla on their port before they come in so that when the nurse comes in, they have to access the port. It numbs that area above that. Elamax is a little faster acting. It takes effect in about 30 minutes. So if we know that we're going to do a lumbar puncture on a child, then the physician will mark the spot where they want the Elamax to be put. You put it on there, you put an occlusive dressing on there, and in 30 minutes that area above where they're going to puncture for the lumbar puncture is pretty much numb. So that's Imla and Elamax. Here's some information about applying Imla. And here's a very old picture of somebody with 80s hair applying Imla or Elamax to their daughter. All right, some other topical things that you can use, topical medications that you can use. TAC, we don't usually use TAC in kids, but I have seen it used in adults before. It has tetracaine, epinephrine, and cocaine in it. Let is the more common one that we use with children. If it's a laceration that's going to have to be sewn up, we try to get some let on it at about 30 minutes before we are actually sewing it up. Most of the time, the let just kind of barely numbs it to where if we need to infiltrate it with lidocaine, then we can do that fairly painlessly because of the topical numbing that has taken place with the Elamax. There are a couple of different, they talk about Numby stuff. We used to have the Numby stuff. We also have the Buzzy, I think it's called. It's a vibration situation, and so you put that on the skin and it vibrates and does something to the pain receptors topically. So that's one that we do have. I don't know how often it gets used. We used to use a J-tip, and a J-tip is a little syringe with lidocaine in it that uses compressed air to force it under the skin. It worked really well, and to be very honest, I'm not sure why we stopped using J-tips. I think it was the delivery syringe issue, but I'm not real sure. But it worked very well. You'd find the place where you're going to puncture with for the IV or for the lab draw. You would kind of pull it to the side so you don't want to constrict the vessel that you're shooting for, and you numb the skin. You depress the little plunger, and it makes a very loud sound like a Coke bottle opening or a Coke can opening, and it numbs that area, makes a little blanched area with a circular target, for lack of a better term, that you can use to start your IV. So it worked really well. We also have cold spray, the vapocoolant spray down there that it talks about. You spray that on the skin. It's very cold, and it kind of numbs that area for a few minutes. All right, epidurals in kids, a lot of times post-surgically, they'll have an epidural. And again, those are, you have to make sure that you assess for constipation, sensation distal to the epidural, etc. Urinary retention, important. And then this talks a little bit more about sedation, what your responsibilities are as a nurse. Here that is, making sure that you have the equipment ready, making sure that that airway is patent, watching their vital signs, watching their O2 sets. All right, here's some things to assess for. We talked about all of those: constipation, nausea, vomiting, and itching. All right, managing procedure-related pain. We talked about using the smallest gauge needle, distraction, get child life involved. Those are all important things to remember right there. So read through that. Chronic pain. Chronic pain is unfortunate in kids. Chronic pain, you have to do a lot of teaching. You have to do a lot of family, I don't know quite what the word is, but family has to be on board. You don't want them to ignore the pain because, you know, kids with sickle cell trait, they do have chronic pain. So you do have to deal with that. And a lot of times parents, and I'm totally guilty, they kind of negate their child's, you know, they say their child's pain, oh, they're fine, they're fine, they're fine. But you do have to address that, and you have to teach parents not to have that attitude towards their child's chronic pain. And then there's our wonderful care plan. I would read through that. Great interventions. In addition to you might see them on the exam or in some prep U questions, you're going to use them in the hospital. So this isn't stuff that you're just going to regurgitate on the exam. This is stuff that you're actually going to use. So I would read through that. All right, and there's your key concepts. So takeaway: FACES scale, Flack scale, the number scale for adolescents, know your Tylenol and Motrin doses, know non-pharmacologic ways to treat pain, all of the developmental stuff, any of the interventions and teaching methods that you can use for parents will be important. Thank you. Have a good afternoon.